Welcome back to Brain Pods. I think we're on number 11 now. Dr. Asadi is back
Correct.
with me. You will remember him because he gave the HHD5 talk on stroke, amongst a few other topics.
Correct.
The third year resident,
Yes, currently a third year resident.
and then plans for after you're done?
Uh, Stroke fellowship, likely. Maybe sleep, who knows?
Yeah, that's not necessary. You get to hear stroke from the stroke expert today. So with that short introduction, we'll go ahead and get started. This is an expansion upon the HHD5 talk that Dr. Asadi gave during your second year of medical school, but you'll notice there's an expansion of content towards clinical management and therapy. Take her away.
All right, so hello again. Rami Asadi with you. Hopefully this will remind you of a few things from your second year course, and then we can maybe build on them just a little bit. So, just a word on what we're trying to do here. So, it's essentially the same thing as last year. We want to give you guys an idea about strokes, their etiology, pathophysiology, and underlying risk factors. Then identify or really remind you guys of some common stroke syndromes you really need to be aware of. And then the new part is going to be stroke management, how we go about really looking at these people with strokes, or at least suspected strokes when they first hit the hospital. So here's the outline. It's just pretty basic introduction, etiology, basic pathophys, overall signs and symptoms, and then treatment. So getting into the meat of it. So first and foremost, what's a stroke? As I mentioned before, there's technically no absolute definition, but grossly you can think about it as any acute loss of neurological function due to any focal vascular injury to the brain parenchyma itself.
So it's stroke is one of those conditions where the name is perfect, right? It is. I mean, the name comes from you were once not you were once fine, and then all of a sudden something happened, and then you have a new problem. And almost when that happens in neurology, it's almost never anything other than acute vascular event. Would you agree with that?
I would.
Which is not to say that occasionally you might not get a stuttering type vascular event, but usually if someone was well, suddenly not well, that's stroke.
Definitely. I think the acute nature is always the thing to sort of highlight and really keep in mind. As far as why you might want to care about stroke, so as we're sort of hinting at, this is an acute neurological emergency. To say that somebody is going along fine and then all of a sudden is not fine, that's not normal, right? Like, that needs to be addressed as quickly as you can. It's very common. It's about 800,000 a year. That's in the United States. The economic impact is not small. It sits at about 185 billion. You can imagine that a person who has a stroke, especially if it's devastating, this person might not be able to take care of themselves, or maybe they can't work.
Yep.
This only kind of gets worse, I think, as unfortunately the country gets a little bit more unhealthy, and people are having strokes and worse strokes earlier.
Yeah.
So this can be a giant problem for the family.
Well, and tragically, it often strikes people in the prime of their life, right? I mean, this is like a lot of cardiovascular disease. It tends to be later, but we see a lot of strokes in the young, otherwise functioning really well, and then this tragic event happens. And we'll get into treatment later, but one of the things I'm really excited about in neurology is how quickly we are revolutionizing the management of stroke. It was not when I started medical school in the 1990s. We had just started thrombolytic therapy. So prior to that, if you had a stroke, there was nothing to do other than to try to prevent you from having another one. That is not the case anymore. There is a great opportunity to rescue brain, but it is a neurological emergency and needs to be addressed immediately.
Other than that, I would say stroke is a great opportunity to examine the basic neuroanatomy and sort of symptomatology. You can think of, on a very basic level, there's not much, it doesn't get much simpler than saying, hey, this part of the brain, I don't know what it does.
Yep.
Stroking it out, and then saying, oh, what doesn't work now?
Right. Right.
It's
Which is it's lesion physiology at its basic. I mean, this was much of what we understand about the stroke. I'm sorry. Much of what we understand about the brain, going back over the centuries, was related to someone had a stroke. They then subsequently had a problem, and then they later did a post-mortem evaluation to look at what part of the brain was
Right.
involved.
Definitely. And then final thing, it's on your shelf in step 2, so hopefully that's enough to get you to care about stroke. And it will be, no matter what you go into, it's going to be on pretty much every licensing exam you ever take.
Yep.
I can tell you that with certainty. Next up, just a few notes about etiology. So we'll get into this a little bit, but roughly it's broken down into ischemic strokes and hemorrhagic strokes. The ischemic you can kind of think of as a brain attack if you sort of if you think about it in terms of the way that you might have learned your cardiology. That terminology is really not catching on, but I've seen a push for it, I think.
Okay.
It's very similar. There are several types, which we will also get into. And then the other 15%, or the remaining 15%, roughly speaking, is the hemorrhagic or the bleeding stroke. So this is where you actually blow out a vessel and you start bleeding into the brain parenchyma itself. This table on the right side of your screen, if you take a look, you'll see that so this blue is the hemorrhagic, the green are the various types of ischemic. We classify these based on the Toast criteria. We'll go over that essentially when you're on the actual floors with us. The other thing I wanted to say is don't worry about the overall numbers. This 85-15% is really plus or minus 5% depending on what study you look at.
Okay.
And I would just go with those numbers. I don't know if you have thoughts
Nope.
on it.
I'll take your word for it.
All right. One thing I wanted to say at the outset, and I do feel this is one of the most important slides in the entire deck, is that stroke symptoms and question answers and patient presentations are largely predictable if you have I think a fundamental understanding of the symptomatology and what you're doing with it. Ultimately, the clinical syndrome can equal the localization, and the localization can equal the mechanism. Thus, the mechanism can be elucidated from the syndrome. It's your sort of if A equals B and B equals C, then A equals C, right?
And we'll discover that a little more as we start going through a few syndromes. We'll recognize, this is probably an embolic stroke based on where the lesion was. This is probably a hypertensive stroke based on where the lesion was.
Definitely.
Got it. Okay.
All right, so getting right into large vessel ischemic strokes. So usually the underlying sort of mechanism, etiology would be atherosclerosis.
So when we're talking large vessels, we're talking about
your carotids, your vertebrals, and then your, I will lay this out in a slide that's coming, but your anterior cerebral, your middle cerebral, and your posterior cerebral. And I think one other's in there is the basilar that I forgot to mention.
I like the basilar.
Basilar's it's a good one. It's a scary one, but it's a good one.
It's a good one. I like mine.
So as far as the pathophys, there's two major ways that you can end up with a large vessel ischemic stroke. That's either a thromboembolism or in situ thrombosis. As far as the risk factors, I've said this last year and I would say the same thing again. Largely, you're dealing with the same stuff that you dealt with in cardio, so don't think that you have to memorize a whole new set of things. It's vascular pathology. It's a clot in the vessels, and so you can pretty much get there the same way. So your hypertension, your hyperlipidemia, smoking, obstructive sleep apnea, obesity all play a role, and are all things we look at and go after with our testing and ultimately our medication choices. So here's a slide just to sort of remind you of the difference between a thromboembolism and in situ thrombosis. So over here on the left, essentially you have a clot that's formed in the heart. It's a thrombus, right? And then little emboli or little clots can break off and essentially go really anywhere, right? It could go to your kidney, it could go to elsewhere in your heart, but in terms of a stroke, it means it's found its way up your larger vessels until it can go no further and it causes a stroke. In terms of in situ thrombosis, so here it's local. You're probably in a vessel that's intracranial and plaque ruptures, and then platelets come and you basically develop an overall an overall thrombus. Again, you can think of it very similarly to how you think of a heart attack, because it is essentially the same process, just in a different part of the body. Here, as promised, is just a few words on what are we talking about when we talk about large vessels. To do that, I would introduce, again, the concept of circulations. The way that we sort of break this down is into an anterior circulation and a posterior circulation. Now, the anterior essentially involves your carotid, so these are your main arteries coming up your neck, right? You have one on either side. Each of them breaks into an anterior cerebral artery that sort of goes towards the front of your head, and then a middle cerebral artery that sort of goes up the center. And then the posterior circulation consists of your vertebrals, so they're kind of coming up the backside. There's two of them. They get into, or they form, or they combine, I should say, into one basilar that then gives off two PCAs, two posterior cerebral arteries. Ultimately, when we're talking about this, the most common strokes come from the MCA territory. And you can kind of think of that, it sort of makes sense, right? If you have something coming up your internal carotids here, it's easier for it to just keep going rather than make sharp turns, is always the way that I kind of remember it.
Makes sense. And all connected by the circle of Willis, the blood beltway, which provides anastomotic
Yes.
perfusion.
So yeah, there's a reason we keep asking you to memorize that particular structure. All right, one other thing that I think helps when it comes to localization is to remember something you already know, which is your homunculus, and then to sort of delineate more of the circulation. So I would start down here. I don't think it necessarily shows up the greatest, but here's the most lateral side of your brain. Here is, we're looking at a medial section. The red is MCA territory, and you can see it's basically the whole lateral side of the brain. Mm-hmm. And then you have this strip up top in the yellow, that's your ACA, your anterior cerebral, and then the sort of U curvature of your posterior cerebral. When you move medially, you essentially are all ACA with a little bit of PCA in the back. Now, keep that in mind, and then let's talk a little bit about sort of your various cortices. So you have a motor strip, and this should hopefully all be hitting somewhere in your memory.
Or you could learn it for the first time.
It's certainly possible. So this green is your motor strip, right? It's the most posterior aspect of your frontal lobe. Right behind it, the first part of your parietal lobe, is the sensory strip. This blue around here is the auditory cortex, and then back here is your visual cortex. And so you can kind of see, or you should probably already be sort of taking a guess as to which large vessel is supplying which area of the brain. One other thing, just to sort of slightly complicate it, but I think it makes it make overall more sense, is if we're looking now essentially from, if this is your lateral and this is your medial, and you have your homunculus, and it's grossly the same for sensory and motor. If you're Googling this at home, you'll find slight differences, but I would say grossly it's the same.
Yep.
You'll notice that basically your face and arm up to the shoulder, right about where your trunk muscles are, this is all lateral. And so you can imagine that's all going to be your MCA.
Middle cerebral artery.
Your middle cerebral artery, thank you. And then once you sort of get over the hump and sort of down into the brain, if I can say that, you hit your leg and your trunk muscles, and you can kind of see how that's probably going to be a lot of ACA. And you've probably seen that one way or the other in the ways that you had to memorize these sort of symptoms for your step one. There's mini tables on that.
I love the homunculus because it lets you know what the brain values, right? I mean, there's just an incredible amount of motor and sensory information coming in from the face and the hand. There is a reason why our species depends so much upon the hand, and our brain reflects that.
So, with that, we can probably start talking a little bit about some stroke syndromes. So, start with the MCA, since that is the most common. So, the way I want to do it is, I'm going to introduce two, I guess, big basic statements, and we'll kind of build on it from there. So, first off, this is an anterior circulation stroke. Put in your mind, anterior circulation stroke means contralateral weakness and sensory loss, just as a general rule. Then, sort of referencing back what we just talked about, the MCA part, this is the arm and face, right? So it's the more lateral part. And you can see that a little bit here. This is a right MCA territory stroke, so you can see how it's hitting the lateral part.
Just orienting the left side of the screen of an MRI is actually the right side of the body, and vice versa. You can think of it as you're looking up at the brain from this individual's feet. And so, yeah, we're looking at a right middle cerebral artery infarction here.
Okay. So then, putting all of that together, what you might expect with an MCA is that you're going to have contralateral arm and face weakness and numbness, primarily.
But not the leg.
But not the leg.
Right.
Correct. So that gives you sort of one aspect. The other thing you might be asking yourself is, well, what about sides? So there's a right and a left side, right? There's two MCAs. So one of the ways that we can address, or at least think about the which side we're dealing with, as well as sort of help, I think, prove to ourselves that we're dealing with an MCA stroke, is to look for the presence of cortical signs. Mm-hmm. This is a large vessel. This is part of large vessel semiology. So we have a couple that are really important and you're going to have to get comfortable with. The first one is aphasia. This deals with the left hemisphere. And there's neglect and extinction. This is a right hemisphere. And then there's gaze deviation. All of these have slides coming up, so I will kind of talk about them a little bit more individually.
Quick before you go on, just to kind of comment, right, left side of the brain, right or left-handed individual. What Dr. Asadi is pointing out is that nearly always the left side of the brain is the dominant hemisphere. And when we say dominant, we mean that's where language is, because language is just so critical for human function. And the right side of the brain is the non-dominant hemisphere. There are exceptions to that, but even amongst left-handers, they still usually have left-sided brain dominance. Am I right about that?
Yes.
Okay.
I used to know the numbers, but it's a very tiny percentage of people that are actually right brain dominant when it comes to language.
All right.
So just going through the cortical signs one by one. So aphasia, this is a disorder of language. I would underline that and try to put that in your memory. It's not dysarthria, which is a slurred speech. It can oftentimes, I think, be confused, especially when family members are giving you a history.
When I think dysarthria, I think brainstem cerebellum issues, more mechanically the production of language later down the course.
Definitely. Aphasia is typically a left hemisphere lesion. So again, this is what we were saying just a few seconds ago. So largely that's where your language is going to be. So largely that's where the language cortex is you're going to find it. You have essentially two big areas. You've probably heard the names before. So there's Broca's. This is the posterior inferior frontal gyrus. If you have a stroke in this area, you can end up with an expressive aphasia. This is characterized by non-fluent speech, but preserved comprehension and insight into one's own deficits. So these people, they're very unhappy, I would say. They're very frustrated.
Yeah.
They know that something's wrong.
They know something's wrong. Absolutely. And tell us about Wernicke's.
Wernicke's is a little bit posterior to that. It's in the posterior superior temporal gyrus. Here you get a receptive aphasia. So these people can give you these fluent, sort of nonsensical speech. You might have heard I believe the buzzword is word salad on your shelf examination. They can make a lot of paraphasic errors, so that could be they're switching words or even switching syllables. They don't really have, the comprehension is really impaired, and largely this word we put at the end, anosognosia, they don't really have insight into the deficit. They're
not aware they have a problem.
No.
Which is really one of the many fascinating aspects about neurology is that there's many cortical. If you have a cortical deficit, you are often agnostic about it. I mean, you're not aware that it's there. And we have a couple of excellent videos to help illustrate this. So we're first going to go over a Broca's expressive aphasia, and what I want you to listen for here is this is a woman who has had a stroke. It has involved her Broca's area of expressive language, and you're going to see she's clearly trying to communicate here, but is failing in doing so, is slurring her words a bit. But mainly, if you just look at her, you can see that she knows that she's not communicating properly.
So now why don't you just tell me what it's like? Tell me what you just told me. but I can't. But because already is she can't, because already we have memory, and so you can't always, so you just there and there and there and there. I can't.
You really feel for her, don't you?
Yeah, that's terrible.
I mean, so she really is trying to explain. She knows there's something wrong. You can imagine she's forming what she wants to say, but she just can't bring it out. Now, contrast this with our next patient who has a receptive Wernicke's aphasia, and you're going to see someone who is blissfully unaware that they're not communicating particularly well.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
With the iPad that we were doing. Like here?
I'd like my change for me and change hands for me. It was happening. I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them.
Good.
This girl was very good and happy. And I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for us, other hands. I don't know what you get, but I talk with a lot of hands for him.
So when I see that, one way to think about it is you're looking at what they lose, but I'm looking at him and I'm thinking about actually what's still functioning. I'm thinking about the Broca's area, which has in it these circuits that are just ready to go with these classic phrases, but they don't match up well at all.
Sure.
And conversely, the woman with the Broca's aphasia, I think about her Wernicke's region, which is still working very well, which clearly comprehends language and wants to express it but can't. So two really fantastic examples of aphasias.
So those are super powerful. I have to just say that. Next up, neglect and extinction. These would indicate a right hemispheric lesion, specifically the parietal lobe. Neglect is the worst of the two, I would say. It's essentially impaired attention or awareness of one side of space. So they just do not attend to one side.
Mm-hmm.
And you can kind of see that in some of these examples here. A person who's essentially drawn a clock and there's nothing on the left side here. Or this gentleman who, I always love this picture, has only shaved half of his face. A less severe form is extinction. This is something, it's a little bit more subtle to bring out. We will have to show this to you, I think, in all its potential glory on the wards. But it's essentially, a person can feel both sides if you're touching each side individually. So if I'm...
Here, you do it on me.
There we go. So if I'm touching him, there we go.
Okay.
If I'm touching his right hand,
I say that one's
it.
moving.
He's touching his left hand.
I say that one's moving.
But if I touch both,
just this one.
Yep. So he loses a side.
Yeah, and so just since the camera's on me, we're reversed here, but this is my right hand and this is my left. So it with the double simultaneous stimuli, you lose sensation to the other side, to the neglected, extincted side.
Yes. All right.
And we have here is an example of neglect of a woman who has had a stroke. And so the stroke has been in her right hemisphere here. You can just see before I even start playing it that she's not attending to the person who is on her left side. and you can see her left arm is just hanging down on the side, even though she can still move it, as you'll see here in a moment.
Hey. Hey. Hey, how you doing? Good. Doing good? All right. So you remember when you told me you like to do board games with your family? Mm-hmm. Yeah? Okay, we're going to do something with cards today. Do you like playing cards? Mm-hmm. All right. What I'm going to have you do, I'm going to have you use this arm. Can you feel that? Mm-hmm. Okay. I'm going to have you use this hand, and you're going to flip the card like that. All right? So don't forget, you're going to use this hand. You can use this hand to help you, but this is the one I want to flip. All right? Okay.
So she can do it. She doesn't. She really wants to use that right hand.
All right, I'm going to go ahead and give you another step.
You can look at the way the therapist is holding her up.
All right. Well, where are you going?
Falls
All right,
over.
can you do me a favor? Look at that mirror right there. Does that look comfortable? No. No? All right. What are you going to do to fix it? Here we go. All right.
And you'll see the occupational therapist, when she wants her to use that hand, she actually has to smack it a little bit to make sure that she gets that extra afferent input.
All right. Finally, as far as the cortical signs are concerned, there's gaze deviation. So this is another helpful clue. It's essentially damage to your frontal eye fields. You have what we call the frontal eye fields on either side of your brain. This is not the strict thing that they do, but the way that I've always thought about it that really helps me is that each frontal eye field is pushing the eyes to the other side. Mm-hmm. And so if you have a stroke, say on your left, and now your left isn't working, the right side's going to overpower it and push your eyes over to the left. So essentially you're going to look towards where the stroke is, or look towards the lesion.
I've always thought of it that way.
Yeah.
All right. Okay, so imagine we are looking at the left side of their brain, and that left side of their brain now has a stroke, and so what you will end up as is a left-sided gaze preference. Yes. So if you open up their eyes will look over to the left side. Interestingly, if these people are unconscious, and you do doll's eye maneuvers on them or put cold water in their ears called cold calorics, you will still get the normal horizontal eye movements going back and forth because the brainstem centers of horizontal gaze are still intact.
All right, so moving on. So next up is the anterior cerebral artery strokes. So this, again, sort of my two big statements to lead us off. So one, it's an anterior circulation stroke, right, just like the MCA, so we're dealing with contralateral weakness and sensory loss. And then when it comes to the ACA, remember where we were looking at that sort of yellow strip a few slides back, and so that was the more leg portions. Yep. And so you're looking at the more medial part of the cortex, and so you're going to end up basically with contralateral leg weakness and numbness. And you can see that actually on this, or you can see the stroke on these two CT images. So on CT, same idea as MRI. So this is the right, this is the left, but compared to the MRI where the stroke was bright, here we're going to see it as less bright compared to or darker.
Hypodense, is that what term they use?
Hypodense is the term. There we go.
So the radiologists and the future radiologists can email me the correct terminology, but I'd call that hypodense.
I think that's the proper
terminology. I will apologize.
And so, and again, so you can see this nice, very well delineated strip of a hypodensity on these two slides. All right. That's just to remind you, again, where the circulations are. So, all right, this is what we're seeing in the ACA stroke. All right. Finally, as far as large vessel, there's the PCA, the posterior cerebral artery. This is a little bit different, and it involves different things. So it's less about sort of weakness, numbness. You start seeing the way that I always remember it. So you have cerebellar issues. You have visual issues because that's where your visual cortex is. It's way in the back. And then because it's largely your vertebrals and brainstem that are supplying your brainstem, you're going to have brainstem deficits. So again, it follows from what's being supplied by what. As far as individual sort of symptoms or signs, Cerebellar leads to ataxia, dysarthria, as Dr. Howell mentioned a little while back, and then nystagmus, which is going to be ipsilateral. For the ataxia, sort of fun thing to remember that I think is helpful is if you watch a person, they might fall towards the side of the lesion. Although you try not to have your patients falling all over the place. As far as visual, there's what we call hononymous lesions. This is visual loss on the same side in both eyes. There's a slide coming up where we'll sort of delineate that a little bit better, but just put that in your heads for now. As far as the brainstem, you're going to get lots of cranial nerve deficits. These are going to be mostly ipsilateral. Really, it's only 4 that crosses, so you can imagine you're going to find it.
Yeah, and it barely crosses, right? It's just sitting right at the midline. So
right.
If you have a cranial nerve deficit, it is nearly universally an ipsilateral problem.
Next up, you can see some crossed findings as far as the motor and sensory tracts. This is because, obviously, to get from the cortex down to your spinal cord to actually elicit movement, they have to run through the brainstem. They haven't crossed yet, so especially
Which
motor.
is at the pyramids.
At the pyramids, right? That's really low. Like motor is right as the medulla is becoming the spinal cord. So you will see that if the stroke is big enough or in the right/wrong place. The other thing is you have your reticular activating system, which really takes up a lot of prime real estate throughout your brainstem, so you can get a decreased level of consciousness. And then nausea, vomiting, vertigo. This, as soon as I hear that, I immediately think posterior circulation stroke.
Yeah, like in the pons or the medulla, the fourth ventricle.
Yes.
Is that what you're thinking?
Or even eighth nerve issues. Can do it.
Sure. And then just a comment back about the sensory tracts, contralateral. So the pain and temperature, as they go in the other direction, afferent input, they decussate almost immediately when they enter the spinal cord, and vibration proprioception, they decussate akin to the cortical spinal tract fibers right at about the level of the pyramids. No, let's cancel the my Wi-Fi there. Okay, all right, moving on.
All right, so here is essentially how we can end up with a hononymous hemianopsia or quadrant.
Sorry about this. This is I'm gonna shut down my Wi-Fi because it's trying to find where it wants to hook up at. Okay, there we go. Sorry about that, everybody.
Right. So here we're dealing with, these are issues basically posterior to the optic chiasm, right? So you're tracking along, and essentially if you hit anywhere along that pathway, you're going to get both sides of the eye.
I'm sorry, both sides of a visual field.
Excuse me, yes. Both sides of visual field out. So if you take off the whole tract here, you'll get the whole half of the eye out. If you reach the point of the optic radiation, so there's superior and inferior, for example, and again, as with everything, so they cross, so superior radiations end up in the posterior part of the visual cortex and vice versa, then you might see a quadrantenopia. We sort of have that here or here. I mean, it's give or take, right? It's never a perfect quadrant.
Right.
And the other thing is, if you take the PCA out, this is how you would end up with this last one here, where you have a whole field out, but you have what we call macular sparing.
Yeah, I think that the pearls to know here is that prior to the optic chiasm, you end up with a monocular deficit. If you're at the optic chiasm, you have this very unique bitemporal hemianopsia, so it's just the lateral field, and that can happen with a pituitary or a hypothalamic region, something that compresses the optic chiasm. Anything posterior to that, you result in a field deficit. And if you get all the way back, you often get a field deficit with central sparing because of collateralization to the critical regions of the cortex that serve central vision. And I guess I probably would just leave it at that.
Works. All right. There's a couple of syndromes that obviously you have to know.
Yep, and we're going to be going bottom up here. So starting down at the level of the vertebral arteries, which get their name because they course through the vertebral bodies, right? So here we are going up from the bottom of the medulla.
All right. So medial medullary, you might also hear it called Wallenberg's, I believe.
Nope, that's lateral.
Oh, excuse me.
Yep.
This is...
In terms of I don't know the name.
I forget the name as well. Sorry.
All right. Which lets all the third years know they don't need to remember the name.
You're never going to use it. So this is the anterior spinal artery, typically at the level of the caudal medulla. So caudal is the lower aspect, right? So rostrals towards the head, caudals towards the tail. You get contralateral limb weakness because you're still above the pyramidal decussation. So you're very low, but you're still not. You still haven't quite had the decussation. You'll also see tongue deviation to the side of infarct. So this is an ipsilateral cranial nerve 12 deficit, and then contralateral loss of proprioception, vibration, discrimination. These are your posterior column signs, and that's because they've already crossed over.
Right, and the medial limnocisc is right here, and here's the motor findings right there. So here we go. Here is, Dejerine syndrome was the name of the medial medullary.
I spoke too soon.
Yeah, Dejerine syndrome. But lateral medullary, which is what we're going to talk about right now, is that sneaky, tricky Wallenberg syndrome, which is this is a common syndrome. I mean, we see this monthly. Would you say?
I believe so. Yeah.
Yeah. I mean,
Quite
this is not an unusual stroke.
I think it happens quite a bit, and you can see. So what I'm about to explain, I think, is sort of the extent of it, or what we consider to be the extent of it.
Yep.
But you can get, I think, 2 out of the 5 or 6, 3 out of the 5 or 6.
Right. We're talking about tracts that go through here because that's where the posterior inferior cerebellar artery serves the lateral medulla,
Yes.
as well as the inferior cerebellum, for that matter.
Correct. So here you'll hit your vestibular nuclei, so it's another way to get vomiting, vertigo, and nystagmus.
Yep.
You can hit your inferior cerebellar peduncles. So this is the lowest. There are 3: superior, middle, and inferior. These are connections between the cerebellum and the brainstem at various points.
Mm-hmm.
Here you'll get ipsilateral cerebellar signs, like we sort of mentioned a few slides ago. So your ataxia, your dysmetria. You're hitting the lateral spinal thalamic tract, so there's going to be contralateral loss of pain and temp from the body. Spinal trigeminal nucleus and tract, you'll get ipsilateral loss of pain and temp from the face.
Which is coursing down. It makes that unusual tract after it comes in from the fifth cranial nerve ganglion, and instead of going up, it goes down.
You'll also hit potentially the nucleus ambiguus. So here you'll get your dysphagia, hoarseness, and an absent gag reflex. It's cranial nerve 10 stuff.
Yep.
And then the thing that pops its way into, I think, just about everywhere, if you're hitting your sympathetic fibers,
Yep.
as they're ascending or descending, you'll have ipsilateral Horner's, which is ptosis or lid lag, meiosis, and anhydrosis.
Yeah.
Always something to be on the lookout for.
I think of these, what I would really remember is I'd remember the ipsilateral cerebellar, and then I would remember crossed pain and temperature loss. So pain and temperature loss on that ipsilateral side of the face, but yet in the contralateral body. If you get that story, this is going to be a lateral medullary syndrome until proven otherwise.
Definitely.
All right, next.
Next up, there's the lateral pontine syndrome. So again, we're sort of continuing to ascend a little bit. Now we've hit the level of the anterior inferior cerebellar artery. Here again, you can hit your vestibular nuclei. So again, vomiting, vertigo, nystagmus. You'll start hitting potentially your facial nucleus, 7, so you can get facial paralysis, decreased taste from the anterior 2/3 of your tongue, and even a decreased corneal reflex. And there's your spinal trigeminal nucleus. This is ipsilateral loss of pain and temp from the face.
Same idea.
So yeah, some of these should feel repetitive at this point. Then your cochlear nucleus, so decreased ipsilateral hearing, which isn't, I think, always evident clinically.
Yeah, I don't know if that's seen me. I don't know if I've seen it.
And then again, sympathetic fibers.
Yep.
So ipsilateral Horner's.
Got it.
All right.
So along that, and I threw this. The poor Dr. Sadi didn't know about this slide was coming, but I threw this one in. If you start talking about the basilar artery, you better recognize how important it is. We can see these catastrophic basilar artery infarctions where you end up locked in. And what locked in means is that you lose all motor function, you lose cranial nerves to the face, you lose all cortical spinal tract descending down into the cervical spinal cord. You lose horizontal gaze because that is in the pons. And so all you are left with is vertical gaze. And yet the reticular activating system is often either fully spared or at least partially spared. You could end up with this catastrophic syndrome where you are awake, you are definitely conscious and in there, but the only way you can communicate is with vertical eye movements. And I have seen a few really unfortunate cases like this. I still remember seeing my first one at Hennepin when I went in to see a guy who was young. He was in his 30s or 40s, had a horrible uncontrolled diabetes. I think he had a hemoglobin A1C of 16, 17, something like that. And he ended up the story is that unresponsiveness. That was the story. And you walk in, and he was not unresponsive. His eyes were wide open and looked at me and was able to go up and down. And so we need speech therapy to help us communicate with these individuals. They'll often create a word, alphabet board to help communicate, but really important. And important to recognize that they are not unconscious. And so oftentimes for locked-in syndromes, we'll put a sign up on the room to let people know as they're going in, this person is not comatose. You've seen a few cases.
That's my very first week here. I saw my first one.
Is that right?
Which unfortunately was also a young guy who had just started a new job, had a new grandkid. I mean, the story was.
Yeah.
So it can and does happen, I guess.
Yeah, and so more stroke therapies is what we need. All right, next.
So here.
We're up higher. We're now in the midbrain. Oh, this is also, I put this one in as well, poor Dr. Asadi. So here we are in this is Weber's syndrome, another name that's useless for you to know. It usually is a branch off the posterior cerebral or the top of the basilar, and you get an infarction right here on one side that knocks out, it knocks out the cortical bulbar and cortical spinal tracts, as well as cranial nerve 3. So what you end up with is cranial nerve 3 lesion on one side, and then on the other side you end up with face, arm, and leg weakness on the contralateral side. And as is usually the case, when you see a cranial nerve lesion, that tells you what side it's on. So if they have a cranial nerve lesion here, or over here, or in the tongue, it tells you what side of the brainstem the lesion's on. Next.
All right, so moving on. So that's large vessel ischemic strokes. Let's talk about small vessel just a little bit. So here you have essentially the smaller vessels that come off these larger vessels we just mentioned, right? Pathophysiology is a little bit different. It's usually chronic damage, essentially due to chronic hypertension. So that's the big one. We did say hypertension and diabetes were significant for large vessel, but here this is really driven by hypertension. By definition, they're small. It's less than 1.5 centimeters. And I think based on how they looked or do look pathologically, they can be called lacunar strokes. They create little lakes.
Yep.
Or it looks like a little lake around the area that's stroked out.
Yep. Yep.
So there's a couple of very common places that you would get a small vessel stroke. So coming off the MCA, you might find where the lenticulostriate arteries go, and this would be your basal ganglia, including the internal capsule, your putamen, and your caudate. Then from the PCA, there's your thalamoperforators or thalamo-geniculate, so thalamus, you probably hear that in the name. And then from the basilar, you have your pontine perforators, so you can get a pontine stroke. And this is quite, these are by far the most common areas.
So you get little strokes here, you get strokes in the thalamus, and you get strokes in the pons.
Here, I always find these actually quite interesting. So there's several lacunar syndromes, small vessel stroke syndromes, that are, I think, kind of wild. So the first is if you hit the posterior limb of the internal capsule, you can get a pure motor syndrome. So contralateral weakness of face, arm, and leg. And that's because all those fibers are all traveling together right in the internal capsule. If you hit the thalamus, you can get a pure sensory syndrome. And this would be contralateral numbness of face, arm, and leg. And note that we're no longer talking just face and arm versus leg. It's the whole shebang.
So this is one of those situations where the smaller the stroke actually results in a more profound motor deficit because the location just happens to be critical. is where all the fibers kind of come together.
Right.
Where you can actually blow out your whole MCA and still be up and walking around.
Yes.
Right. All right.
You can think of the real estate keeps getting smaller and smaller as you go down.
Yes. The Manhattan or the Hong Kong
There we go.
of myelin real estate.
I love it.
We're struggling.
Finally, there's the ventral pons. This can give you an ataxic hemiparesis, so contralateral ataxia secondary to the pontocerebellar fiber injury, and then contralateral weakness secondary to the pyramidal tract injury. So you're sort of in the right place for both of those.
Yeah.
And, it can
And then just one thing about, see, ataxia hemiparesis, this is one of those situations where, you're like, well, I thought cerebellar signs were ipsilateral. They are, for all practical purposes. The main problem here is actually the weakness. You just see a little bit more ataxia. If you see cerebellar findings, think ipsilateral. Next.
All right, here's just a series of MRIs that show very small strokes. You can see this little ditzel there that if I actually point to it, I'd cover up with the marker here. Here's one, and then here's sort of its correlate over here. Two things to note. There's no cortical signs, right? That was a large vessel thing. And then, as Dr. Howell was just saying, so often you're going to get the entire hemibody affected, and that's because you're going from these strips, say like your motor strip, which is covering this relatively large area, into this tiny little compact space where all these fibers are. So ultimately, these can be very devastating to people, even more so devastating than the MCA strokes. This is just a review slide for you.
It's a nice slide. If you know this slide, you're doing well.
Yeah. Everything we just said at its most simple can maybe be broken down here. All right. Next up is cardioembolic stroke. So, as is sort of indicative from the name, so essentially this is coming from some sort of, an embolus is coming from the heart. I would also add in the aorta.
Yep.
I mean, potentially part of the heart. Your big risk factor here is going to be atrial fibrillation. We always look for it. We'll talk about that when we talk about diagnosis and management. The other things that you've probably come across, so heart valves, these are really thrombogenic, right? That they can just create, platelets just love to adhere to these things. Also a paradoxical embolus via PFO. I've never seen it. It's on every test ever. So you can imagine if you have like a DVT in your leg and that breaks off, and then there's a direct connection between the right side and the left side of your heart, that it can just keep going. Clinically, it's a little bit difficult to distinguish these from any other stroke because they can look like any other stroke. Depending on the size of the embolus and where it goes, it can be a MCA stroke. It can be a small vessel stroke. What you look for, of course, is heart stuff, but you might not see it immediately. Mm-hmm. One of the sort of clues that sometimes pops up is that you can imagine if the heart is throwing a bunch of emboli, then they don't always have to go to the same place, right? So if you see a bunch of different strokes in different areas, both hemispheres, it's something to consider, strongly consider. As such, cardiac monitoring is a strong part of our workup.
And you're really mainly looking for what you see right here, which is narrow QRS complexes without identifiable P waves, which is an atrial arrhythmia.
All right. Next up is a transient ischemic attack. So this is a brief episode of neurological dysfunction. So basically, this looks like a stroke.
Yep.
You couldn't tell.
It came on suddenly. Mm-hmm. So I mean, just like the other strokes, it came on suddenly, but then it resolves.
Yes. The idea, therefore, is if it's resolving, there's no permanent damage, i.e., there's no true infarct. If you happen to be reading older review materials or older books, you'll see that it used to be defined as anything as a stroke-like attack that lasted less than 24 hours. Really, it's less than an hour, and even that's probably too long. You can imagine if you're having this bit of ischemia, and we know that our brain cells start to die at about 3 to 4 minutes. You're
not going to stick around and say, well, maybe this goes away in 6 hours, maybe it goes away in 12 hours. That is a product. That's a good sign that our field is moving forward because we don't screw around. We just go ahead and take care of it.
Right. I think the way that I most commonly come into contact with these people is something happened at home, but they're maybe normal by the time they hit the emergency room. But you're still gonna move, and you're still gonna work this up and actively address things.
Yep.
So the way that we sort of risk stratify this is by what's called the ABCD2 scoring criteria. So this is, it's a mnemonic, right? So age, blood pressure, clinical features, and then duration and diabetes. Each of them you get a few points. and then essentially, depending on how many points they get, maybe
Yep.
you can let them go home and quickly do a workup, which involves an MRI, risk factors like blood tests for whether or not they're diabetic and so forth. But almost always they're coming in.
Yeah.
And I think
For this reason right here, right? Half of them are going to have a stroke in the next 2 days.
Right.
Yeah.
And so, despite so this is the sort of recommendation right here. My experience is that anybody over a 1 is almost certainly coming in, and we are heavily pushing for them to come in. And
Yeah.
so you'll see that on the wards, I think.
Yeah.
All right. Moving on to hemorrhagic stroke. So here, same idea. There's focal brain damage, but this time it's intracranial bleeding instead of a clot. There's a couple of types. There's intraparenchymal, which is directly into the brain tissue, and then there's subarachnoid. You'll get that in another
BrainPod
lecture.
3. They've had it already with Dr. Starks.
There you go.
Exciting. Fantastic. It was great.
Here's another slide that just sort of delineates the ABCD2 score and essentially your 2, 7, 30, and 90-day risk
Yeah,
of stroke,
look at that.
depending on
Look
your
at that.
stroke.
Yeah.
So look how that just,
Ugh.
I mean, it's basically exponential.
Yep.
So these people need to be addressed quickly.
Okay.
All right, sorry, going back to hemorrhagic stroke. So again, this is essentially just a retelling of the previous slide.
Yep.
So this one is dangerous. So as we mentioned way at the beginning, it's only 10 to 15% of all strokes, but it's a much higher mortality. These are scary. I think when they come up, you have to really address them quickly. The big risk factor is again hypertension. If you compare it to ischemic, you'll see trauma, vascular malformations, underlying malignancies, or even hemorrhagic transformation of an existing ischemic stroke are really what get you there. Clinically, they can be quite different, so you can get more headache, decreased level of consciousness. This is because the skull, I mean, this is a closed compartment, right?
Yep.
And when you're putting in a bunch of blood, you're really not much space. So pressure is going to go up, and this can start causing a headache and pushing on things like your reticular activating system. 2 types we want you to know are intraparenchymal and then cerebral amyloid angiopathy. So as far as the hypertensive, a lot of this is going to sound very similar to what we just said, and it's because it is. So it's small vessel, blows out instead of infarcts. Again, the common risk factor is hypertension. And again, you're going to see the basal ganglia, the cerebellum, and the pons as being really the common areas. And so the difference is now you have a bleed, which on a CT is going to be bright, versus a stroke, versus an ischemic stroke.
Yeah, ischemic
Infarction.
stroke, which is hypodense.
All right. As far as cerebral amyloid angiopathy, so this is the second most common cause of an intraparenchymal hemorrhage. Here you get essentially the blood vessels are weak, and so they're very prone to breaking from periods of increased of increased blood pressure. Usually this is coexistent with Alzheimer's, right? So if it's amyloid, it's these A beta proteins. That's where it's essentially coming from.
Yeah.
And the other sort of difference here compared to what we just said is these are more likely to have a lobar stroke, right? So you can see that down here. It's in the lobe. It's a lobar stroke as opposed to what were more deep strokes or pontine strokes that we were seeing previously. This is just to show you amyloid deposition along the artery if you're looking at it on pathology.
Is that the Congo red stain? I don't know.
I'll say yes.
Well, I don't know. I didn't ask the smartest guy I know, which is Dr. Brent Clark. But.
Yeah. All right. So finally getting into evaluation and diagnosis. So just to state equivocally again, this is an emergency, and so a lot of what we will present when you're on service with us, you're going to see us doing a lot of things simultaneously. It's not really like the clinic, I would say, where you get to think some things out and sort of think about the best plan. You got to move.
You know, all of us, even if our own lives or a family member, you're gonna see someone who has a transient neurologic deficit. It's often subtle, often no pain, and what is human nature? To dismiss it, right?
Right.
I mean, it is, and this is. I come to you all from the future. As you take care of yourself, take care of your family members, take care of your patients.
Sure.
By treating this as a 4-alarm fire and go in immediately and get it taken care of, because time is brain and those neurons are dying very quickly.
All right. So the other thing is, as we go through, I'm going to try to break it down a little bit into initial and subsequent follow-up. But again, remember that a lot of these things are happening together.
Keep going, keep trying.
There we go.
You got it.
So, acutely. So let's say a patient presents, there's some sort of neurological dysfunction. Their arm and leg doesn't work or something is off. The things you're going to do immediately. So history is super important. Time of onset dictates a ton of things. This is, somebody's got to get this as best they can whenever a patient comes in.
As quickly as possible.
Yes.
Yep.
The other thing you want to know is meds. The big ones being warfarin, I would say. You always
Yep.
want to know if, because this will, I'll get to this, but this will dictate some of what you can or cannot do. We do a quick examination. It's not a great neurological examination in terms of the purest sense of the word, but it's great for looking at strokes, and it's called the NIHSS.
And you can do it in a couple of minutes. And even if you've never done it before, you can Google the NIH stroke scale, and it'll print off for you, and you can stand by the bedside and do it at the same time as you're clicking through it. So this is just Google NIH stroke scale.
And that's essentially what this is. This is what we run through real quick. So you can see everything from level of consciousness to arm strength, which we're not actually pushing or
Yep.
pulling on the patient,
Yep.
to their body, to potential for dysarthria, best language,
Yep.
things like that. You score it, and then that helps you make your decisions. Also in the acute setting, so as patients come in, there's acute dysfunction, we're going to image this person, and they're going to get a CT head. And the point is to rule out a bleed. You have to know that there's not a bleed. It's going to
Mhm.
dictate a lot. In real life, so in testing life, I'll say this first, the answer is always, what's the next best step? CT head, non-contrast.
Yep.
In real life, we want to get the vessels right away too, because you might see a clot on the
Yep.
CT and angiography.
Yep.
Then immediately grab some labs. You want to know ARO2 saturation, glucose, because hypoglycemia can mimic a stroke. You got to know their electrolytes. Creatinine's important. CBC, PTNIR, and then troponins, because it's not unheard of that a patient is having a heart attack at the same time.
Yep.
Unfortunately.
Yep.
So, in the acute phase, continuing on, the whole point of the last slide was just to confirm that there's a stroke, that it's not a bleed, and that we can intervene with one of these two things. That's the big thing that we're thinking about in the acute phase. Can
Yep.
I give this person TPA, otherwise known as Alteplase, which is a clot-busting medication? It activates plasminogen, and so ultimately you're cleaving fibrin clots. Again, so that's only ischemic stroke, so you would not dare give that to a person who's bleeding.
Yep.
And again, going back to why we care about the time of onset, we can only use that up to 4.5 hours from the time of onset. After that, you're going to cause more harm than good, and so we won't do it.
Why? What happens after 4.5 hours?
So essentially, after 4.5 hours, you can think of, you've had this stroke,
Mm-hmm.
and behind the area where there's no blood flow,
Yep.
You're going to have neurons dying. You're going to have a brain structure, a brain parenchyma that is.
And the vessel, right?
And the
the endothelium distal to the clot is dying as well.
Sure.
Right? And so what happens when you open that up and perfuse that dead vessel?
So you're going to blow it.
You bleed out into it. Yeah. So after 4.5 hours you can still lyse the clot, but the problem is you're going to cause more problems by bleeding into it. All right.
So, the other potential intervention is a thrombectomy. So this is where we actually stick a catheter with a stent retriever.
And you have a little bit more time for this, fortunately.
Yes, that's the big thing. So you go up and you actually try to pull the clot out. This is up to brand new information, exciting in our world. This used to be like 6 hours, 12 hours. Now it's up to 24.
Yeah.
Again, this is only large vessel strokes. Typically, it's going to be MCA. Sometimes the ACA. We really don't like putting it up to your vertebrals into the basilar, because if you screw up, that's game over.
There's a lot of clot. There's a lot of calcium plaques there that you can dislodge and fleck loose, and yeah.
It's scary. It's basically only in life or death situations. But you do have more time to do it, and really the only limitation otherwise is the size of the technology. That's really why we can't go farther than what I just listed.
So along those lines, so let's get a CT scan. If you have the CT scan over here on the right, you do not see any blood. The brightness right here, that's from a calcified pineal gland. Otherwise, this is all okay. Go ahead and give Alteplase TPA. You'll note that you actually might not see the stroke. Right, the stroke itself often takes several hours to manifest itself on a CT scan. So if you have somebody who clinically has a stroke, CT scan normal, you still give TPA. Conversely, if you have blood here, it is no go for launch, right?
Right.
Yeah. All right.
All right. So here's just a little pictorial representation. So TPA, it's in a hanging bag like every other medication. We give it IV, in it goes. As far as the thrombectomy, the endovascular treatment, here you're actually sticking a stent retriever up, you're trying to grab it and then pull it back out. So quite basic on a certain level. Moving on to sort of subacute period, sort of during the hospitalization. So obviously you're going to try to stabilize the patient because they may have multiple things going on. You're going to ultimately get an MRI of the brain. This will confirm that there's a stroke if you didn't see it on CT, hopefully. And it can also give you clues about etiology and age of the stroke. So it's something we typically talk about on service, but there's a sort of progression of a growing brightness, then sort of lack of brightness on the MRI and various sequences of the MRI. If you didn't get it at the beginning, or it wasn't, nobody got it before you arrived, you would get your vessels, usually with an MRI at that point. And then you go looking for risk factors. So you're testing your A1C for glucose, your LDL. An echo is for the heart, looking for AFib, looking for problems or even a thrombus in the heart.
And also just severe heart failure, right? I mean, if their ejection fraction is super low, that's thrombogenic as well.
Right. If they smoke, we try to get them to stop. We do our best.
They'll still sneak out at 2 o'clock in the morning for a little trip to flavor country sometimes. But in all seriousness, a nicotine patch can be quite helpful while they're in the hospital.
Right. And then when and where needed, we'll give them a sleep study.
Yeah. So sleep apnea is a risk factor. It's a reversible risk factor because you can treat it, and you don't need to do the sleep study in the hospital. Usually, just arranging for it to be done outpatient is fine. So we have talked about stroke. We've talked about how important it is. We've talked about the vasculature. We've talked about different types of stroke, and we've talked about the initial phase of management. So now we're going to talk a little bit more about, in detail, about treatment of these stroke syndromes.
Yes. So here, this slide is just to sort of, I think, put it as simply as I can. So there's a little bit of a difference, again, between acute and long-term approaches. Your overall goal, if there's an ischemic stroke, is to basically bust up or remove the clot one way or the other.
In time.
In time, yes. If you're past a certain point, then all you're doing is risk factor management. But if you can do it, that's your thrombolysis with TPA or your thrombectomy. Long term, it becomes about trying to prevent the next one. And I say try because there's nothing we have, I think, that's 100%.
Sure.
But we still try to get people on the aspirin or the statin or these things.
Yep. We did forget one thing on inpatient management. DVTs, right?
DVTs, yes.
Right. So you want to get them on a DVT prophylaxis, either low dose heparin or just pneumoboots, right? So it's sequential pneumatic compression devices.
Yes, I think we use those probably more commonly than the heparin. But.
Got it.
All right. So long-term management. So this is largely guided by what you find and the etiology of the stroke itself. We term this secondary prevention. As I just mentioned, it's not 100% effective. This usually, I say that because we usually have to talk to the family about this. Because people can kind of come in angry, I think, if there's been a second stroke. But he took his aspirin, but he did this. But nothing's 100%. The standard list essentially is as follows. So just about everybody's going to end up on aspirin, unless for some reason they can't. There's the newer antiplatelets like Plavix in certain cases.
Clopidogrel, right? Right.
Yes.
Dipyridamol.
Thank you.
Yeah. All right. We're trying to avoid trade names here.
Thank you.
I don't have any endorsements yet. I'm working on it.
Yes, I have no disclosures for this lecture. If you find that their LDL is up, you'll put them on a statin.
And the threshold is low, right? I mean, we really want to drive the LDLs down.
Yes.
But what's the number?
Less than 100, unless they have diabetes as well, in which case it's less than 70.
Yeah.
There are brand new recommendations that I think essentially are telling us that we might as well put statins in the water. Everybody should be on them. So I think it's good. Statin is probably going to go the way of aspirin. It's going to be just standard.
And then it'll cause some other problem,
right.
I'm sure.
Hypertension, you give them an antihypertensive. It's kind of, pick whichever one, depending on risk, what they can handle or not handle.
Yeah.
Diabetes, you're going to end up typically on metformin or insulin, AFib. There's rate or rhythm control. So this is your aspirin, your warfarin, or your beta blocker. A lot of this you would have heard about from your cardiology lecture. Again, smoking cessation, and obstructive sleep apnea. They get a sleep study, and if needed and if tolerated, BiPAP.
Right. Yeah. So sleep apnea is the collapse of the upper airway during sleep. I guess I would change BiPAP here to just positive airway pressure therapy. We usually start with just continuous positive airway pressure therapy.
Okay.
Bilevel is a little bit more comfortable. It's mainly used for treatment of obesity hypoventilation, which some of these patients may also have.
All right. So moving on to diagnosis and treatment of the hemorrhagic stroke. So the diagnosis looks essentially the same, right?
Yep.
You're starting off with the CT, and the CT is great for blood. You should pick this up at the beginning. This isn't something where you have to do an MRI to sit and confirm. Same idea, history, very quick examination, same basic labs, because essentially when all that's happening in the moment in the emergency department or on the floor, you might not yet know what you're dealing with, but you're going to get there, right?
Yep.
So here, the acute phase looks just a little bit different. So the big thing here is blood pressure. So this is arterial blood, right, coming out at arterial blood pressure. And so you want to lower that. And you want to lower it fairly quickly because it's just going to keep pushing blood through the broken vessel.
Yeah.
If they have a high, if they were on warfarin, they have an INR, you're probably going to try to reverse that because that's going to give them a much larger tendency to bleed. The other thing, you'll manage glucose, temperature. These are all things that are related to their hospital stay. We know that if they have poorly managed glucose, if they have a large fever, this is all really bad for the neurons that have just had this period of hypoxia. If needed, if there's too much pressure, you might consider an EVD.
What is an EVD?
So this is essentially the neurosurgeons typically create a connection. They bore a hole through the skull and go all the way into the ventricle, and sort of you can remove the CSF from the lateral ventricles to relieve pressure.
Is it an external ventricular device? Is that what that stands for?
Yes.
Okay. All right. Fascinating. Cool.
So, and again, just going back to etiology, so you're going to be looking for any falls or trauma as far as history that you care about, potential medication overdose, especially if they were on warfarin, drug use, things like that. Those are all important. Long term, a lot of these people get angiography because maybe they had some sort of inherent vascular malformation, as we mentioned, something along those lines. So you're going to go looking for that and address that as needed. Because some of those need to be intervened upon by either the neurosurgeons or the endovascular team.
Yep.
Blood pressure management is sort of the cornerstone, I would say, of management, because that's going to be the single most important thing to preventing another one.
Yep.
Lifestyle modifications, and if the person is on warfarin or some sort of anticoagulant, we reassess. We don't automatically say they're not going to be on it.
Yeah.
But you need to sort of reassess the need, I think.
Got it.
All right. Next up is, I guess, a series of essentially miscellaneous types of strokes with their evaluation diagnosis.
Which doesn't mean rare. It just means this doesn't fit into our original schema particularly well. Go ahead.
So here's the list. We'll go through each one. Each one has a slide, so we'll go through all of them, one by one. So first up is a carotid or vertebral dissection. This is a tear in the artery wall, either in the intima or the media. So blood then enters that new sort of false lumen. A thrombus can form, and then you can have emboli come off that and go more distally into the cerebral vasculature.
So here's the tear, right? And then the clot forms inside here, and then that can break off.
Yes.
Right, as well as just cause lumen narrowing and obstruction even without throwing a clot off, right?
Correct.
This happens. When I think dissection, I think young people, because this can happen with people with young vessels, and can be really tragic because it's often it's large vessel stroke, so it takes out a lot of territory.
Right. To be honest, everyone I've seen is in a young person.
Okay.
It's overall up to 20% of ischemic strokes in young adults. So this is before. So average age of stroke is actually above 70. It's sort of early stroke if you're talking late 50s into the 60s.
Yeah.
It's sort of accumulation of risk factors. But once you're talking about a 40-year-old or especially a 30 or 20-year-old, these people shouldn't be having a stroke.
No.
Unless there's some sort of genetic issue or something like that.
Yep.
Trauma is the big one. Neck manipulation. So people at the chiropractor, people who fall while doing yoga. This is actually why I've seen the dissections that I've seen are those two causes.
Whiplash injuries,
Whiplash.
right? Yeah.
You diagnose it via CT or CTA or MRI or MRA. So again, you need the angio part, the angiography part. And then treatment. So aspirin is small and stable. I would say largely we don't put these people on aspirin, but it is an option if you think you're okay. Most of these people are going to end up on anticoagulation. I would say at least for the first 3 to 6 months. Then you might switch to aspirin for another, I would say, 6 months, because it takes these things a while to heal.
Yeah.
And even then, you get a little bump, little scar tissue at the end where the dissection was. Sometimes in really severe cases, you'll do some angioplasty, but that's not the norm. This is just to show you how if you have, so here's a normal carotid. If you have this sort of false lumen and a bunch of blood that's dissecting into it, you can really narrow what's supposed to be the true lumen. This I thought was just funny. I've never actually seen this, but the puppy sign is a bilateral carotid dissection. So here's your little false lumen on both sides. Next up is watershed strokes. So this is ischemia in a border zone. So border zone, basically, you're talking about the areas where the ACA meets the MCA circulation or the MCA meets the PCA circulation. And so in times of like really bad hypoperfusion, so low blood fluid or low blood volume
After a cardiac event,
something like that, these are the areas that might typically stroke out. And this picture is just to sort of show you where those are. So here's where your ACA is meeting your MCA. Here's another area where your MCA is meeting, I'm calling it the LCA, but it's essentially a continuation of the ACA. And then where your MCA is hitting your PCA. So we would diagnose, just like always, CT or MRI, and your treatment is going to be the underlying cause. This, I think, is just another, I thought it was good to look at.
Yeah,
so this is where these are your strips, your ACA, and then your ACA,
Right.
MCA, and your MCA, PCA.
so right on those, and they after a cardiac or hypoperfusion event, there's these very classic syndromes you get where the watershed is, which is again, go to the homunculus, right there. It's right there at the shoulders and the hip, the pelvic girdle, and so they have strong. It's referred to as the man in the barrel syndrome, right? Or woman in the barrel syndrome, and they have good strength in the hands, good strength in the feet, but they can't shoulder abduct and they can't hip abduct. That is watershed syndrome.
All right.
And there's a couple pictures of it.
Yeah, here's just showing. So here you can kind of see these couple of areas in the ACA MCA border zone. Here, ACA MCA and MCA PCA. It's very, very well delineated. All right, next up, cerebral venous sinus thrombosis. So here's where you're actually hitting the venous channel. So you can stroke out. We've consistently talked about the arterial side, but the venous side can stroke out as well. Here, the epidemiology is a little bit different. So things like OCP, so high estrogen states, or steroids, even trauma, or just straight compression from a local mass can do it. You're going to get symptoms that are a little bit different, kind of resemble, I think, the hemorrhagic strokes.
Okay.
So headaches, decreased level of consciousness, blurred vision can happen, nausea, vomiting, and the big one is seizures. I think can really come out with these if you're.
Because you're irritating the cortex is
Right.
what if you think about where the veins are, they're near the cortex, and also if you have a venous stroke, it doesn't obey arterial territory. So everything we talk about, ACA, MCA, PCA, those rules go out the door when you're talking about a venous infarct.
So, yep, signs, seizures, otherwise papilledema. So sometimes if you look in this person's eyes with the ophthalmoscope, you'll see signs of increased pressure. Focal deficits can happen, and they can go all the way to coma. Again, diagnosis CT or MRI with MRV, so there's a venous or a venography side.
Got to remember to order it, though.
Yeah,
Yep.
it's not automatically done. These people end up on anticoagulation. And here is just to sort of show you what this looks like. So here is your superior sagittal sinus.
Yep.
And it's kind of lighting up.
That's a
You don't
clot
wanna
in
do
there.
that. Yep.
Yep.
All right. Here's another one where you can see just the transverse on the left is just gone, and that's because there's a clot in there. All right. Next up, so just some global hypercoagulable state. So anything that makes you hypercoagulable can
Sure.
cause a stroke, right?
Yep.
So common ones, and we will oftentimes, especially in younger patients, go looking for these with a hypercoagulable workup.
Yep.
So your hyperhomocystinemia, your protein CNS deficiency, your factor V Leiden, anticardiolipin, lupus, anything that gives you a high estrogen state, any active cancer.
And different these tend to affect different beds, right? I mean, some affect arterial territory, some affect venous. Really remember to think about malignancy, though.
So diagnosis is the same as always. So CT, MRI, right? Because if a patient's presenting with
Yep.
a stroke, you're running
Yep.
through the same algorithm.
Yep.
And then treatment really depends on the cause. You're going to try to address whatever the underlying risk, whatever the underlying etiology was, as possible. And then finally, illicit drug use.
Yep.
Something you always have to be, I would say, keep in the back of your mind, even when you
Especially
think
for younger people, people at risk, anything sympathomimetic, right? So the cocaine, amphetamines, those sorts of things.
Cocaine, just a word on mechanism. Cocaine can do it by any number of ways, but the big one is usually direct vasoconstriction and then vasospasm. It's really irritating
Mm-hmm.
the blood vessels. You can also, if a person is bolusing themselves with a dirty needle,
Mm-hmm.
then you can end up with a clot in the heart, and you can get it sort of the traditional way, but
Yep.
one or the other. Amphetamines, you're actually more likely to get a hemorrhagic, essentially due to high blood pressure during the time that you are on the drug. Again, CT and MRI is the way to diagnose it, and treatment is, you're going to address the stroke itself, any complications that come out of it, and then really the big thing is stop the drug use.
Right.
So-
Right. Antibiotics if it's an endocarditis
Right.
type story.
And any social factors we, in real life we try to address those as
Well, great. That was a whirlwind. You covered a tremendous amount of stroke. Thank you very much, Dr. Sadi. Next on Brain Pods will be Volume 12, which will be Headache, which will be myself and a very special guest. Thank you so much. Best
Pleasure.
of luck in your future endeavors, and thank you for educating us about stroke today.
Thank you, sir.